a scientific study of spread and the control of the disease in a population, which helps to understand where the disease is coming from and who it is most likely to impact. The information gathered can then be used to control the spread of the disease and prevent. The three major epidemiological techniques are descriptive, analytic, and experimental. And although all the three can be used in investigating, the descriptive one is the one which is used most often. It is estimated that globally 40 million people are affected by RHD and over 3 lakh die annually. And that is much more than the COVID that we always talk about. And this is according to the WHO in 2018. Nearly 60% of the deaths are premature. India has the highest prevalence globally, almost 27%, and contributes to the 25 to 50% of the newly diagnosed cases and hospitalized. Dr. Padmavati rightly said, unfortunately, India is in the phase of epidemiological transition. On one hand, there is a substantial burden due to RSD, and on the other hand, resources are scarce. Hence, it is very important to know the new zones criteria and the importance of it. In the past, 200 years ago, there was not a single rheumatic heart disease in our country. And then 1 rupee was equal to $2. And then once the Britishers' rule came and we became poor, 43 million trillion dollars were looted, and then it became so rampant. Not only the $1 became 80 rupees, the people also started suffering, and almost, the malignant type of rheumatic fever, the very severe one, was seen in India. And at that time, if you see from 19th century till the 1963, almost 25 to 50% of the hospital admissions were rheumatic heart disease. And now in the 20s, 1988 to 2006, if you see the epidemiology, incidence has come down considerably. Now it is anywhere between 0.6 to 4% and per thousand cases. And that is the change in the epidemiology. And thanks to the present ECHO criteria, the things are much better. This is a 1 year, 11 months old child with the erythema marginatum. And that's how what we teach 5 to 15 years is not true, because we'll be missing if we do not diagnose the younger children. And this is another 5 years with the erythema marginatum. So in the just 3 months in Jaideva, when we studied, we saw that almost 17% expired despite the maximum optimal treatment, and hence it is a neglected giant, and as a result we have still continued to have. And this is my prospective study quoted in the zones criteria of 2015, and here I showed that ECHO can prevent both overdiagnosis and underdiagnosis. And here you can see that the beaded appearance is not only on the mitral valve, it is there on the papillary muscle as well as on the aortic valve. So this is how this is the beaded appearance, and I saw that this is added in the world thing. And the echo is the key. So here you can literally not only make out the mitral regurgitation, the caudal tear, and that's how this was published in the Cardiology in Young in 2005, and this also has been quoted. So my criteria is almost used by everyone, and here it is so important that you can see that this is the myxomatous valve in case of the mucopolysaccharidosis, where only echo score is only 4. That is a mitral valve prolapse and the MR. Whereas the other side, if you see in the right side, you can see that echo score is almost 10, and that is definitely rheumatic, and this is not. And as on today, our auscultatory techniques have come down, the skills have come down considerably, and when we compared, you can literally see that the clinically diagnosed is much less compared to the echo diagnosis of the pathological MR, AR, and TR. And as a result, rightly, today, the echocardiography is added as a major criteria, and thanks to the zones criteria, people who agreed. And in fact, when I presented about the zones, the echo criteria, Then the president of zones criteria, Dr. Patricia Ferreri, and also Ed Kaplan, who is now, they were there in the audience, and then they were so impressed, and they started that it has to be. Now you can see that the beaded appearance like a chain of pearls, and the mitral valve prolapse and the caudal tear almost like the histopathology. And as on the today, the caudal tear, the echo score is 10, and this is so important to know the caudal tear and what is the cause for that. Unless this is seen, no amount of putting the steroids will help these patients. So the dilated cardiomyopathy with the central MR, functional MR can be made out, and this is just a 3-year-old boy diagnosed as a congenital mitral regurgitation. But when I did the echo, the patient had all the features of rheumatic fever, and then thickened valve, and then the beaded appearance, and you can see that the aortic and the mitral valve also is there. This is the classical. So age is not a criteria because epidemiology is changing and the younger generation are affected. So this is the 13-year-old child with the first degree block, and the patient had this thing, ASLO positive, C-reactive protein positive, and there is no difficulty in making the diagnosis. But here you can see that club-like mitral valve, and only the tip will be prolapsing. That is the peculiarity of the rheumatic fever. So this patient was diagnosed in a medical college where I studied my MBBS, and then put on penicillin prophylaxis. And when I saw, immediately I said, this glistening endocardium cannot occur in the rheumatic fever. And then when I did the short axis, I could make out that this is the Al-Kappa as I thought, and that was confirmed by the angiogram. So this was a patient treated in NIMHANS for the subendocardial, like tuberculosis. And then because of the murmur they sent, because of the murmur and the fever and the raised ESL, they had put the patient on the steroid, and ultimately you can see that there is a subaortic membrane. So this is how echo can distinguish whether it is truly rheumatic or not. So here you can see that there is a non-compaction and the flail PML. In rheumatic fever, the posterior mitral leaflet is fixed or reduced in mobility, and here this is not. So this is not a rheumatic because it gets only scored. And apart from that, echo can show that whether there is a past history of rheumatic disease, and this is the perforation. You can literally see the perforation of the AML, and that perforation can give rise to the MR. And this patient was diagnosed as a dilated cardiomyopathy, but unfortunately when I did the echo, already ejection fraction was just 15, but this happened to be MR and AR due to the rheumatic. Had they known the echo criteria and made the diagnosis in time, probably we could have saved this patient. So today the impact of the echo is so much that even the subclinical carditis can be made out, and whatever we were taught, the 50% of them do not have the past history of rheumatic fever is wrong. The 50% of them were not detected, not diagnosed, not put on penicillin prophylaxis, and hence the subclinical carditis is also equally important. And hence the writing group says that echocardiography with the Doppler should be performed in all the cases of confirmed as well as the suspected cases of rheumatic fever, so that we can not miss them going into the rheumatic thing. This is the severe mitral stenosis in a child, and this is another 12 years with the severe changes. And here this patient with the giant left atrium had the vegetation and embolized and giving rise to the gangrene, and as a result these patients go for the surgery, and otherwise they will not. So this I presented in TCT, and the juvenile mitral stenosis, comparing to that, it is more malignant, and as a result the submitral thing is much more, and your balloon can be trapped in the submitral structures, and hence one has to be careful so that you don't cause the mitral regurgitation and the severe mitral regurgitation. And especially when you try to open up when the valve submitral structures are almost fused, you can cause the mitral regurgitation. So instead of one, there are two jets of the MR, and this is what happens. And hence, friends, it is very important to know that whether there is a tricuspid valve involvement, invariably organic tricuspid valve involvement also could be there, and the TSTR can be there. And this is a just 2 years, 3 months old baby with the 0.4 square centimeter orifice, and this is not congenital, this is a rheumatic. Congenital mitral shoot, and the parachute mitral is different. So this TS and TR, MS is because of the rheumatic. So epidemiology is definitely changing. To conclude, the apparent decline in the RH3 in Bharat is not uniform. In the Bimaru state, it is still very high. And the RH3 continues to remain a major cardiac illness with the enormous disease burden that translates into huge economic and the social losses. The RH3 is not gone, but it is a neglected giant. Echocardiographic assessment in patient is crucial in controlling the program. And this is in this direction, the new zones criteria of 2015, it is definitely going to change the epidemiological phases. In India, we say that malnutrition, low weight, poor hygiene, poverty, illiteracy, ill-advised, reaching late, all these things, lack of prophylaxis is there. But friends, believe me, obstacles are those which are frightful things which you see when you fail to have the goal. Our goal is to have zero rheumatic fever by 2025. To achieve that, it is extremely important to have practice the echocardiography in such a way that you do not miss a single case. So protecting and preserving the heart of the children is not a charity, but the duty and the social responsibility of each one of us, especially the cardiologist and the pediatric cardiologist. Thank you very much for your kind and the patient hearing.
Thank you, Dr. Vijayalaxmi Suresh, for an excellent talk, and you have proved all the major criterias with all the features which Dr. Chopra mentioned. Legend of legends.